Hello, ladies and gentlemen, our new programs. Source, book, the M.D. Anderson Manual of Medical Oncology. Our subject topic is myelodysplastic syndromes. Myelodysplastic syndromes, MDS, refer to a group of hematopoietic disorders characterized by ineffective hematopoiesis and increased risk of transformation to acute myelogenous leukemia. Median age of patients with myelodysplastic syndrome MDS is 70 to 75 years, and it is likely that environmental factors play an important role in the pathogenesis of this disease. Myelodysplastic syndrome is classified according to WHO, World Health Organization criteria, and a number of prognostic scores can be used to calculate survival and risk of transformation. Cytogenetic alterations, more frequently involving chromosomes 5 and 7, are common in myelodysplastic syndrome and help in prediction of prognosis. Over the last decade, we have witnessed significant improvements in supportive care and therapeutic modalities for patients with myelodysplastic syndrome. These include growth factor immunomodulatory agents such as lenalidomide and hypomethylating agent including 5-azacitidine and decitabine. In this chapter, we summarize our knowledge of myelodysplastic syndromes and the treatment approach we use at MD Anderson Cancer Center. The MD Anderson approach to the patient with myelodysplastic syndromes. Every year, approximately 250 to 300 patients are referred to our center with a diagnosis of myelodysplastic syndrome, although percentages vary from month to month. Nearly 30% of patients referred to us with a diagnosis of myelodysplastic syndrome receive a different diagnosis in our center. In most instances, the final diagnosis is that of acute myelogenous leukemia, but other benign and malignant conditions are often observed. Therefore, it is critical to confirm the morphological diagnosis of the patient referred, and it is usually important to repeat a bone marrow aspiration and biopsy at the time of initial revolution of the patient. Once the diagnosis is confirmed, the next more important step is to calculate the risk of patient. Most clinicians and investigators use the IPSS score to perform such analysis, but newer, potential, more precise models have been developed. In general, Patients with low or intermediate 1 risk by the EIPSS or those with less than 10% blasts in the bone marrow are considered as having lower risk disease, whereas those with excess blasts or intermediate 2 or high risk disease are considered as having higher risk disease. And this explanation continuing, but we would like to cut for this point and other subjects to be continued, epidemiology and etiology. The incidence of myelodysplastic syndrome increases with age. Most patients diagnosed with this condition are more than 60 years old, with a median age at diagnosis of 75 years. Incidence is higher in males than females, with a 2:1 ratio. The incidence in the United States is 30 to 35 individuals per million per year, with a relative yearly increase in the reported incidence, probably related to increased awareness of the disease and reporting efforts. The risk of developing myelodysplastic syndrome is related to the individual racial background in the United States. Myelodysplastic syndrome incidence is highest in the white population. Myelodysplastic syndrome patients from Asia present a younger age. The underlying cause of phenomenon is not known, but may reflect genetic differences between different racial group populations of myelodysplastic syndrome. Patients in Asia have a similar frequency of karyotype abnormality as European and American cohorts, although they may have less frequent alterations of chromosomes 5 and 7. This combination of younger age at diagnosis and lack of chromosome 7 alterations can explain the longer survival observed in patients from Asia. There is no known cause myelodysplastic syndrome. A small number of patients appear to have either genetic or environmental risk factors. Genetic syndromes such as Down syndrome, Bloom syndrome, and Fanconi anemia are associated with the increased risk of myelodysplastic syndrome, which often present earlier in life. Genetic polymorphism that influence the activity of enzymes responsible for metabolizing toxic chemicals or chemotherapy drugs, for instance, may influence an individual's predisposition to myelodysplastic syndrome. Polymorphisms have been described in the cytochrome P450, 3A, glutathione S transferase, and NADPH, quinine quinine oxidoreductase enzyme systems that increase the risk of developing myeloid malignancy. Environmental agents may contribute to developments of myelodysplastic syndrome by causing toxic damage to hematopoietic stem cells. A causal relationship between occupational exposure to benzene and radiation and the development of myeloid malignancy has been demonstrated. Exposure to organic solvents and pesticides has also been implicated in the development of myelodysplastic syndrome, and an occupational history of exposure to these chemicals may be associated with an increased incidence of cytogenetic abnormalities associated with the poor prognosis. There is no correlation between myelodysplastic syndrome and socio-economic status. The most significant risk factor for the development of myelodysplastic syndrome is previous exposure to chemotherapy or radiotherapy used to treat antecedent hematological malignancy or solid organ cancer. Treatment-related myelodysplastic syndrome constitutes a minority of myelodysplastic syndrome diagnoses, but may be increasing in prevalence with improved survival rates after successful cancer therapies for solid tumors. T myelodysplastic syndrome usually presents 5 to 6 years after initial cancer treatment and generally has a poor prognosis. Patients treated for lymphoma are at risk of this long-term complication, with up to 2% of survivors from Hodgkin disease developing treatment-related myeloid malignancy. Lymphoma patients who undergo autologous hematopoietic stem cell transplantation appear to be at a particularly high risk of treatment-related myelodysplastic syndrome or acute myeloid leukemia, with incidence rates in some centers of up to 10%. The other topic, clinical and laboratory features. At the present time, most patients with myelodysplastic syndrome are diagnosed incidentally while performing a CBC analysis, either as routine or because of non-specific symptomatology. Anemia is the most common cytopenia in myelodysplastic syndrome and is associated with progressive fatigue. Lower percentage of patients present for investigation of bleeding or bruising secondary to thrombocytopenia or infection related to neutropenia. Physical examination is often normal with hepatosplenomegaly present in patients with chronic myelomonocytic leukemia or overlap myeloproliferative neoplasms. During follow-up of the patient, a change in the severity of cytopenia or rapid worsening of symptoms may indicate disease transformation. Patients suspected of transformation required prompt investigation. as 20% of patients develop acute leukemia throughout their disease course. Initial assessment of patients suspected to have myelodysplastic syndrome should include a complete blood count. Complete blood count, CBC, reticulocyte count, and complete serum chemistry, including B12, vitamin B complex, B12, folate, iron studies, ferritin, and erythropoietin level. Bone marrow aspirate and biopsy with samples taken for an iron stain and cytogenetic studies are required. Myelodysplastic syndrome still requires morphological assessment of the disease. Cytogenetic studies may confirm the presence of clonal hematopoiesis and provide additional important prognostic information. Analysis of specific gene mutations such as JAK2, JAK2, RAS, or FLT3 is probably not indicated in all patients at the present time, but may in time allow for the use of targeted intervention using respective inhibitors that are now in clinical trials. In general, no patient should be diagnosed as having MDS, myelodysplastic syndrome, without knowledge of the clinical and drug history, and no case could be classified while the patient is on growth factor therapy, including erythropoietin. Morphological features of myelodysplastic syndrome. Morphological classification of myelodysplastic syndrome is based on 500 cell differential count on the bone marrow aspirate and leukocyte differential performed on the blood smear. Table 5.1 shows the different subtypes of myelodysplastic syndrome under the new revised World Health Organization myelodysplastic syndrome classification. The analysis determines the percentage of blast presence in the blood and bone marrow, provides an assessment of the number of myeloid lineage involved in the dysplastic process, and the iron stain determines the presence and number of ring sideroblasts. And continue. Cytogenetic and molecular analysis. The cytogenetic abnormality is found in 40 to 50% of primary myelodysplastic syndrome in patients with lower risk disease and is higher in patients with more advanced risk. Cytogenetic analysis of hematopoietic cells derived from the bone marrow aspirate provides important additional information in the assessment of patients with myelodysplastic syndrome. A karyotypic abnormality provides evidence for the presence of clonal blood disorder, which may be particularly important. The morphological changes are not clear. Other laboratory studies, flow cytometry is not required for the routine diagnosis of myelodysplastic syndrome, but it may sometimes provide valuable supplementary information. Flow cytometry can confirm the presence of a specific myeloid lineage within the marrow and may also identify aberrant expression of cell surface markers that are indicative of clonal cell population. This may have diagnostic significance in confirmed abnormal hematopoiesis. Diagnosis. The classification systems used to group different myelodysplastic syndrome has evolved over time with increased understanding of the biology and genetics of the disease. And continue a lot of detailed prognosis. The prognosis is patients with myelodysplastic syndrome is very heterogeneous. The development of clinical systems that allow accurate prognostication of individual patients into low and high risk categories has proven essential to the guide rational management decisions and allow the introduction of investigational drug protocols. The International Prognostic Scoring System is the most widely used system for assessment of prognosis and treatment planning. It provides an assessment of the prognosis of primary myelodysplastic syndrome patients at the time of initial diagnosis. And these articles continue therapy. Treatment options include transfusion of blood products, growth factors therapies, erythropoietin, for instance, with or without colony-stimulating factors, and non-growth factors therapies with immunomodulators, lenalidomide. You know, lenalidomide, immunomodulator, and other functions blocking angiogenesis. You know, generally cancer, colony proliferation, and increasing neoplastic cells at the end, so much waste product and inadequate energy and nutrition, then inadequate oxygen, and then last condition, arteriogenesis, venous, some blood production, proliferation, that to give support neoplastic cells to emigrate more livable area. Immunomodulator lenalidomide and epigenetics drug treatment, azacitidine and desitabine. some different chemotherapeutic and supportive oncological therapeutic components. For instance, deferoxamine therapy reduces iron deposition or other recombinant erythropoietin. Erythropoietin therapy has been explored as an alternative to red cell transfusion in patients with low risk myelodysplastic syndrome. Recombinant erythropoietin in various forms, including apoetin alpha, apoetin beta, and the long-acting darbepoetin have been studied in different cohorts of patients. Continue. Different hypomethylating agents, cytotoxic chemotherapy, immunosuppressive therapy, and continue different style. That's all. This program finished here, and we want to continue new program. Philadelphia chromosome negative myeloproliferative neoplasms. Philadelphia chromosome negative myeloproliferative neoplasms. The field of myeloproliferative disorders has evolved considerably since the sentinel observations made by William Damenschek in 1951. He had commented in the editorial in the journal Blood to put together such apparently dissimilar diseases as chronic granulocytic leukemia, polycythemia, myeloid metaplasia, and the Guglielmo syndrome may conceivably be without foundation, but for the moment at least, this may prove useful and even productive. What more can one ask of the theory? The central feature among the myeloproliferative disorders is effective clonal myeloproliferation without dysplasia. Other features shared by most myeloproliferative disorders include involvement of the multipotent hematopoietic progenitor cell, marrow, hypercellularity, predisposition to thrombosis, hemorrhage, and marrow fibrosis, and more recently, mutation in different tyrosine kinase, for example, JAK2 Janus kinase, platelet-derived growth factor receptor, and KIT25, when the concept of MPD first proposed is considered of 5 disorders: chronic myelogenous leukemia, polycythemia vera, essential thrombocythemia, chronic idiopathic myelofibrosis, and erythroleukemia. Over the years, erythroleukemia was reclassified under acute myeloid leukemia, the remaining four: CML, PV, ET, CMP are recognized as classic myeloproliferative disorder. And continue detail. Other subject: polycythemia vera. Polycythemia vera means real. Polycythemia vera is clonal disorder involving a multipotent, multipotent hematologic progenitor cell in which there is an accumulation of phenotypically normal red cells, granulocytes, and platelets. The word polycythemia is composed of the Greek words poly, many, cyst, cells, and hemia, blood, indicating too many blood cells, red, white, and platelets. The term vera is a form of Latin word meaning true, real, true, making a distinction between polycythemia vera and host of other conditions that can result in the increase in the number of red blood cells. The main feature of the disease is elevated red cell mass associated with predisposition of thrombosis, increasing hematocrit, associated with predisposition of thrombosis because increasing the viscosity of blood stream, blood moving. Polycythemia vera is disease of the elderly. In a large observational study of 1,638 patients with polycythemia vera, median age at diagnosis was 62.1 years. Only 4% were less than 40 years old in this patient cohort. The median survival is long, approximately 20 years, although inferior to the general population. And continue. Clinical features. Presenting constitutional symptoms seen in 30 to 50% patients include headache, weakness, pruritus, fatigue, dizziness, and sweating. Thrombosis and hemorrhage are the most common serious complication of this disease. Splenomegaly is seen in 70% patients and hepatomegaly in approximately 33% patients. Mild leukocytosis can occur with polycythemia vera, as can thrombocytosis. Thrombocytosis can lead to the ocular migraine and erythromelalgia burning pain in the feet or hands associated with warmth and erythema. Some patients are asymptomatic and are discovered on routine blood counts. Bone marrow is typically hypercellular with megakaryocyte pleomorphism in the PVSG01 study cellularity of pretreatment bone marrow. And number 281 range from 36 to 100%, means 82% with the absence of sustainable iron in 94% patients. Cytogenetic abnormalities are infrequent in a large retrospective study of PV patients. And number 137. Cytogenetics were abnormal in the only 11%, trisomy 8 being the most common, and had no impact on either thrombosis risk or survival. Thrombosis is the most serious complication of the disease. In a large study of 1,213 patients with polycythemia vera thrombosis, both arterial and venous, occurred in the 41% patient overall 64 thrombosis, were at presentation of before diagnosis 36%. During follow-up, thrombosis is presenting manifestation in 15 to 20% patients. Ischemic stroke and transient ischemic attack account for majority of arterial thrombosis at diagnosis. Arterial thrombosis is more common overall than the venous thrombosis. Yes, diagnosis, treatment, continue. Essential thrombocythemia. Essential thrombocythemia is characterized by persistent thrombocytosis with a predisposition of thrombosis and bleeding. Essential thrombocytosis is not a cytogenetically or morphologically defined disease entity and remains a diagnosis of exclusion. It is the disease of the elderly, and the median age of diagnosis is 55 to 60 years with a female to male ratio of 2:1. It is important to exclude reactive causes of thrombocytosis. Most of times the underlying cause apparent. Post-splenectomy, acute infections, blood loss, other MPN such as polycythemia vera or chronic myelogenous leukemia can present with thrombocytosis, and therefore it is important to exclude these before diagnosis of essential thrombocythemia is made. Continue. Clinical features. With the increasing use of automated blood counters and routine blood count screening, more patients with essential thrombocythemia are being diagnosed in asymptomatic stage. Constitutional symptoms are uncommon in essential thrombocythemia. Vasomotor manifestations such as dizziness, lightheadedness, acral paresthesia, livedo reticularis, erythromelalgia were noted in 34% patients in one series of 147 essential thrombocythemia patients. And continue. Different therapeutic application. Cytoreductive therapy, increasing cells, and therapeutic application, logics, philosophy, discount, and reduce the cells, cytoreductive therapy. Hydrea and other some different tactics. Antiplatelet therapy, and so on. Special issues, primary myelofibrosis. Primary myelofibrosis is a clonal disorder of multipotent hematopoietic progenitor cell of unknown etiology characterized by myeloid cell proliferation, megakaryocytic atypia. Marrow fibrosis, leukoerythroblastic peripheral blood picture, extramedullary hematopoiesis, and splenomegaly. The median survival is around 5 years. In a recent review of 1,054 patients with primary myelofibrosis, the median survival was 69 months. Different chemotherapeutic tactic application. Chronic eosinophilic leukemia, hypereosinophilic syndrome. Chronic eosinophilic leukemia, hypereosinophilic syndrome. Hypereosinophilic syndrome is characterized by chronic eosinophil overproduction in the absence of obvious reactive or clonal causes of eosinophilia. Eosinophilic tissue infiltration may involve the heart, skin, central and peripheral nervous system, lungs, spleen, liver, and gastrointestinal tract. Diagnosis of hypereosinophilic syndrome requires the presence of an absolute eosinophil count that greater than 1.5 10.9 liter. At least 6 months and evidence of end organ damage. Patient with hypereosinophilia who are found to have clonal disease. Cytogenetic or molecular abnormality proving the existence of malignant clone. Treatment, conclusion. Mast cell disease. Mast cell disease is a heterogeneous group of disorder characterized by clonal expansion of mast cells and their excessive accumulation in various organs such as skin, bone marrow, gastrointestinal tract, lymph nodes, liver, and spleen. Clinical course can vary from no minimal symptoms to diffuse systemic involvement. Mastocytosis has been classified into 7 subtypes by the 2001 World Health Organization guidelines. Cutaneous mastocytosis, indolent systemic mastocytosis, SM with associated clonal hematologic non-MC lineage disease, MC leukemia, MC sarcoma, and extracutaneous mastocytoma. You know, mast cells existing intracellular cladogranules that existence histamine. When the non-cell genetic biological pathogenic agents or physicals or others non-self dynamics that to include inside of our bodies these granules, purine and histamines releasing that our vessels dilatation and our immune system, our soldiers, immune system, macrophages, lymphocytes, leukocytes, and other immune systems suddenly come here and make phagocytosis of foreign dynamics. The different clinical features, symptoms of mastocytosis can be divided into those due to mast cell mediator release or to those due to mast cell organ infiltration, vasoactive mediator, you know, histamine, another functional name, vasoactive mediator, histamine, leukotrienes, prostaglandins, topical hormones released from mast cell can lead to itching, flushing, lightheadedness, syncope, palpitations, diarrhea, heartburn, fatigue, and headache, and can be exacerbated by infections, alcohol, exercise, and medications. Common sites of organ infiltration include skin and gastrointestinal tract. Urticaria pigmentosa is the most common skin manifestation characterized by reddish brown. Reddish, just symptomatic signaling of inflammation. Reddish brown and maculas and papules. The scratching of affected skin characteristically lead to development of urticaria and erythema. Diarrhea sign. Erythema. Erythema is red signaling, outside flashing. Gastrointestinal involvement can present as chronic diarrhea. Why? Because mast cell granules, vasoactive mediator histamines, pouring, and our soldiers' immune system and foreign dynamics make war, and so many secretion, so many cellular destruction, and at the end broken down of our intestinal system, normal physiology disorder, and absorption of digestive different foods, absorption problem, and continue later. Gastrointestinal involvement can present as chronic diarrhea. Steatore is dying the lipidic fatty acid lipidic dying of fetus. Steatore, malabsorption, and ascites. Anemia is the most common hematological abnormality. General anemia is chronic condition. This is general, typical condition. Anemia is the most common hematological abnormality due to bone marrow infiltration, and peripheral eosinophilia is seen around 20% patient. Bone pain and fracture can also occur. Diagnosis relies primarily on the identification of neoplastic mast cell in various organs. Bone marrow examination is imperative for SM diagnosis, as most adults with mastocytosis have underlying bone marrow involvement. That's all today, and this program finished. At this point, our future programs should have been continued. The topic of lymphoma and myeloma. Thank you so much. Thank you very much. You are patient. Our programs may be firstly difficult but different sources, books, very famous books, later to be continued, Abelov, Rosenberg, De Vita, Hellman, other big textbooks of American Cancer Society organized this very famous oncologists all over the United States of America, oncologists, academic staffs. Step by step, we would have been to that possible to understand all difficult subjects step by step. Thank you very much. Thank you so much. You are patient. I hope see you again next broadcasting programs from Consultant Medical Oncology, North Cyprus TV channel Onco Duo. Thanks, Lord.